All right, there we go. So thank you everyone for taking the time to join us for this afternoon's webinar hosted by North Carolina Medical Society Foundation and the North Carolina Medical Group Management Association. My name is Danielle Snyder and I'm with the North Carolina Medical Society Foundation. We are thrilled to have you joining us today. Just as a reminder, the NCMGMA's mission is to maximize the value and effectiveness of medical practice leaders through educational programs, information exchange, networking, and professional development opportunities. The Medical Society's mission is to provide leadership in medicine by uniting, serving, and representing physicians and their healthcare teams to enhance the health of North Carolinians. We have enjoyed our collaborations with these monthly Lunch and Learn webinars we produce for our membership. In each of our shared educational opportunities, we embody these two missions, this virtual meeting being no exception. Today, our presentation is focused on the Diabetes Prevention Program. This presentation will address the growing epidemic of type 2 diabetes in primary care, and we'll discuss actions that physicians and care teams can take immediately to identify and manage their patients with pre-diabetes, including referral to an evidence-based lifestyle change program. Throughout today's presentation, you can submit any questions or comments in the chat box. We do plan to have time at the end of the presentation to answer your questions. We will be recording today's presentation, which will be made available to you after today's session on the North Carolina Medical Society YouTube page. We will also be emailing out a link directly to the video within the next week. So without much further ado, I'd like to introduce our two speakers today. First, we have Karen Smith, MD, a graduate of Hahnemann University School of Medicine. She trained at the National Congress of Family Physician Residents, North Carolina Academy Family Physicians, Duke University, Cape Fear Valley Medical Center, and Fellow of American Academy of Physicians. Dr. Smith has been practicing since 1992 with a private practice in Rayford, North Carolina since 2003. Dr. Smith's practice specializes in family medicine. Secondly, we have my very own colleague, Franklin Walker, who is the former CEO of medical surgical practice and adjunct faculty member of UNC School of Public Health and Department of Health Policy and Management. He holds an undergraduate degree from UNC Chapel Hill and an MBA from Xavier University. Franklin concentrates most of his efforts towards rural and underserved populations in North Carolina. He oversees the North Carolina Medical Society Foundation's Community Practitioner Program, which improves access to care by offering educational loan repayment to providers who will work in underserved areas. He also directs the Society's efforts to establish accountable care organizations in non-metro areas, and through Project OBOT-NC, he directs opioid use disorder treatment programs. Thank you both so much for being here with us today. And Dr. Karen Smith, I will go ahead and turn it over to you.
Thank you so much for that wonderful introduction. It is truly exciting to be here to talk about diabetes prevention. This is a topic which all of us can actually have impact, and we can make a difference. The Diabetes Prevention Project, a North Carolina approach. We could go to our next slide. Okay, and thank you. I've been a physician in Rayford for over 29 years, and so this activity really is near and dear to me. So what are we going to do today? We're going to identify just the onset of diabetes mellitus, and what about the intervention for pre-diabetes? What can we do when we know that the patient is at risk for the development of diabetes? And then what about some very early treatment options, the regimen that can be used? Next. Okay, so here it is. Join us in making North Carolina diabetes free. There is a statewide initiative, the Diabetes Free North Carolina, and it does have an impact in terms of what we can do, our physicians, our care teams, all of us together in healthcare to make a difference. And so the Diabetes Prevention Project is actually a national project, and it utilizes the lifestyle change, low cost, and sometimes free options for people who are at risk for the development of diabetes. And today we're going to get your commitment to help make a difference. So we're asking North Carolina's primary care physicians to lead the way. We want you, by the end of this, to know how to refer eligible patients to the National DPP Lifestyle Change Program. And after you've identified who these individuals are. Next slide. So let's prioritize prevention. It is time for us to make a difference with prevention. And that's what this is all about today. Next slide. Okay, type 2 diabetes. It affects millions of Americans and thousands of North Carolinians. It is amazing. 23 million people in America are diagnosed with diabetes. And our population is 252 million throughout the country of every person that lives here. What about North Carolina? We have 798,000 people who are diagnosed with diabetes, and our population is 8.2 million. This data needs to change. And we're going to move to the next slide. Okay, what is the impact? And we're talking about a significant cost, $327 billion with $237 billion in direct medical costs for the treatment and management of diabetes, and $90 billion because of reduced productivity. Individuals can't work, they can't be part of the different lifestyles that they have. And in North Carolina, we're looking at $9,600 a year on the average in terms of the medical expenses that's attributed to diabetes. An individual with diabetes, the cost of their care is 2.3 times higher in expenses than those without diabetes. And that's just the cost, that's the financial part of it. We've already attributed a lot of the burden, and we're going to talk about how we can make a difference. Next slide. So COVID-19 affects people with diabetes, and COVID-19 has impacted our communities in a significant way. And so those individuals who already have diabetes mellitus and who unfortunately now have COVID-19, we saw loss of life. And it was more than just one area of our country. It was all over the country. It was a global impact. And I'm saying was, it still is. We need to make a difference because COVID-19 and diabetes is not a good combination. Next slide. 84 million American adults have pre-diabetes, meaning we have information in our systems that's telling us these individuals are at risk to develop diabetes, clinically diagnosed diabetes. I just diagnosed one individual 30 minutes ago with diabetes, hemoglobin A1C 8.2, who presented to the hospital with congestive heart failure 30 minutes ago. And what we're trying to do is identify those individuals with pre-diabetes so that we don't get to that stage. Next slide. Okay, so here's our patient, Mary Alice. She's a 47-year-old patient who presents to the office, and she's distraught to hearing of her grandmother's new onset of diabetes mellitus. She wants to be screened for this disease that has complicated several members of her family. Now, her random fasting glucose test was 120. And so let's see what we're going to do for Mary Alice. Next slide. So what are the clinical guidelines and the evidence related to diabetes prevention? Let's see what we can find out. Next slide. Here it is. This is a slide. If you don't get any other slide out of today's presentation, here is the slide. Identification of patients with abnormal glucose. Pre-diabetes, hemoglobin A1C 5.7 to 6.4. Fasting plasma glucose 100 to 125, and an oral glucose tolerance test between 140 and 199. If these three parameters exist for a patient that you're caring for, that individual has pre-diabetes. We want to stay out of that red zone. Once that A1C gets to 6.5, fasting plasma glucose is 126, and the oral glucose tolerance at 200, we're in the red zone. That's not where we want to be. And so everything in yellow, I want you to ingrain it, put it in your mind. If you see it, No, that is pre-diabetes. We must do something. Next slide. And so the U.S. Preventive Services Task Force has already noted that an abnormal glucose, that is a grade B recommendation. Screen all adults aged 40 to 70 and who have a BMI greater than 25 or greater than 23 if they're of Asian descent. Screen for diabetes. And then we want the fasting glucose, the hemoglobin A1C, and the glucose tolerance test. Remember the yellow, remember the yellow, remember those numbers. And when do we want to do this? Every 3 years. We want to check patients every 3 years. Next slide. What about other populations? What about other risk factors? Okay. And so what if an individual has a family history of type 2 diabetes? Mary Alice, her whole family, she stated. And so those individuals, if there's a first degree relative, whether it's a parent, a sibling, a child, screen. Even if their BMI is lower or the age is lower, screen. What about the medical history? Gestational diabetes is still playing a role. And then polycystic ovarian syndrome. And then we look at our racial and ethnic minorities, particular individuals of African American, American Indian, Alaskan Natives, Asian Americans, Hispanics, or Latinos, or Native Hawaiians or Pacific Islanders. We may have one or two or many of these individuals who we're taking care of in our patient populations. And so we want to stay on a high alert. And we want to be able to go ahead and identify prediabetes in our populations that we're taking care of. Next slide. There's additional identification guidelines. And the key that I want to see on the takeaway for this slide is the access to the 2021 Standards of Care Guidelines for diabetes. Just about everything that we'll be talking about today, it comes directly from the guidelines. And I encourage you to please put this app on your phone, put it on your hard drives, get this information on your computer so that you can refer back to it in terms of not only pre-diabetes, but the management of diabetes. Because it's those of us who are treating diabetes, if we are treating it with good information, it will make a difference. The other thing that I want to highlight is what are those conditions that often alert us that an individual may have diabetes. And so my patient who came in this morning to be discharged with congestive heart failure, cardiac disease. And so oftentimes individuals will present with either a hypertensive urgency or a heart attack where they're having acute myocardial infarction. And lo and behold, we find out that their glucose level is elevated. Well, is it elevated because of the stress of the condition, or did they actually have diabetes all along that's now showing itself? And we want to pay attention to these other conditions. Next slide. So what are we going to do? We have identified an adult with prediabetes. Remember the yellow. I'm going to keep referring it. I'm going to keep saying it. Remember the yellow, because if you have these individuals, what do we want to do? So we could refer them to the National Diabetes Prevention Program Lifestyle Change. It works, and we actually do it. And I'm going to talk about the success of what we've been able to do. Medication. Yes, medication does exist for prediabetes, but if we can not have to use the medication, that would be better. But we're going to try to make sure that we have everything in our repertoire that's necessary. And then what about referral to medical nutrition therapy? That's another option. Actually, it's a main option that we're going to talk about. Next slide. So the USPSDF abnormal glucose recommendation. Well, that's it. We want to offer or refer our patients with abnormal glucose to intensive behavior counseling, interventions that will help promote healthy diet and physical activity. And note, I said intensive. We're not talking about using intensive medication. We're saying really get in there and let's make a difference in terms of that individual's behaviors. And let's see what we could do to diminish their risk for actually developing diabetes. Next slide. And some of the additional management guidelines, when we look at the lifestyle behavior change program, if we do this, it's a grade A recommendation. It does work. And there's a variety of eating patterns that can be considered to prevent diabetes. And so if we can have individuals know what are the foods and what are the patterns that you've taken on in your life, how can we modify it and make a difference? And we know that utilizing the certified technology assisted diabetes programs, it does work. Grade B recommendation, and it's cost effective. We already spoke about how many billions of dollars that diabetes cause us to spend in our country. So what can we do to actually diminish the cost? Next slide. So the diabetes prevention program, what is it? I've been talking about it with excitement and enthusiasm. Now let's talk about the details of the program. And we're going to go to the next slide. Okay, here it is, the National DPP program. And this curriculum I love. It is actually a core curriculum, 16 weekly sessions for the first 6 months. I have patients who actually participate. One of my patients says, well, our group meets on Sunday evening and it's perfect. And they're meeting on Zoom and they're meeting online. And I said, this is wonderful. But then there's a follow-up. And so after they've completed that initial core curriculum, they continue to get follow-up up until additional 6 sessions. And so not only are we providing information from a source that doesn't require us, the provider of care, but we're using a team, a collaborative outside of the medical home to help us with treatment and prevention of diabetes. And so that's what we're doing. We are actually helping participants sustain healthy lifestyle changes and weight loss. And we're going to see how much weight loss makes a difference. Next slide. And so there was a control trial that was done, randomized control trial of over 3,000 people with elevated risk for developing type 2 diabetes compared to placebo versus that of metformin and versus that of the intensive lifestyle intervention. Now, here's the findings. It reduced the incidence of diabetes by 58%, lifestyle intervention, compared to doing nothing, or maybe just us telling the patient, you're at risk for prediabetes, decrease your carbohydrates. That's placebo. We don't want to do that anymore. But what about the pharmacotherapy? And I mentioned medication, metformin. Metformin was also used and it reduced the incidence of diabetes by 31%. But that was a medicine and that was 31%. But if we really went in there and we did the intensive lifestyle intervention, we had an ROI of 58%. Now that makes a difference. Next slide. So let's understand the program just a little bit more. And this is where I think it's making a difference for our patients. We have trained lifestyle coaches who are teaching the classes. These individuals know what they're talking about and our patients trust what they're saying. There's an emphasis on prevention and empowerment through personal action plans. I joke with our patients. I said, look, I'm not sending you to a course that you're going to take on Zoom and somebody's going to tell you to eat rice cake and tofu. I know you don't eat rice cakes and I know you don't eat tofu. So we want to make sure that we actually give recommendations that you can live with, that you can actually do in your home. The program is CDC approved. It has already been demonstrated to work. And I showed the slide beforehand, and the quality assurance. So we already know that this works. And what about the weight loss? We're talking body weight loss of 5%. So not only are we impacting diabetes, we know that we're having impact on other conditions. Next slide. To enroll, the participant does need to meet all of the criteria, 18 years and older. have a body mass index of greater than 25, or if they're Asian American, greater than 23, not diagnosed with diabetes type 1 or type 2, and not pregnant. All of the following criteria must be met. Now, they also need to have either a fasting plasma glucose of 100 to 125, a 2-hour glucose tolerance test of 140 to 199, or an A1C of 5.7 to 6.4. Remember the yellow zone, the yellow zone, the yellow zone. So we want to keep that in mind. If they've had a previous diagnosis of gestational diabetes, or if they have an elevated score on a pre-diabetes risk test questionnaire. And that questionnaire is available through the program. And last night, I actually worked with some computer gurus to see how we could actually get it in our system so we don't have to have paper. Next slide. So improving prevention and practice, that's what it's all about. That's it. Let's go to the next slide. So in North Carolina, over 50% of adults have a BMI that is categorized as overweight or obese. And every year, more than 50,000 adults are diagnosed with diabetes. And what is the total cost? Greater than $13 million. So we know an estimated 2.8 million adults have prediabetes. That's 1/3 of our state, 34.8% of our state population. This project will literally impact 1/3 of our population. This is amazing. Next slide. So diabetes-free North Carolina. Blue Cross Blue Shield of North Carolina has prioritized the prevention of diabetes by investing $5 million in a 3-year initiative that supports this project. And the funding covers the cost of enrollment and participation in both in-person as well as the virtual program for all North Carolina adults. This is payer agnostic. It does not matter what their insurance program is or what their provider is. We can really move this forward. Next slide. So the National DPP Lifestyle Change Program Referral Options. How can we get our patients into this program? So we have 3. We have OCHI, which is our community health initiative, North Carolina NC Cares 360. We have the DPP Navigator, and we have a direct referral source. I'm going to ask Franklin to kind of chime in and talk a little bit more about OCHI while we're on this slide.
Sure. Thank you, Dr. Smith. The OCHI software was created by the North Carolina Medical Society Foundation a couple of years ago in connection with the NC Alliance of YMCAs. We built this software so that a physician like Dr. Smith can direct message a referral for DPP over to her local YMCA or other healthcare organization. That referral is caught electronically by OCHI, and it allows the health coaches at the YMCA or other community-based organization to run the patient through the DPP program and return that outcome data to Dr. Smith. We're now active in 13 different locations of the YMCAs across North Carolina, and we're also working with Duke University Medical System to enhance this arrangement. Dr. Smith?
Thank you, and I appreciate it. And then our state, and certainly we've all been excited about NC Cares 360s. Again, I was meeting with our EHR and our telecommunications gurus last night, and I see some exciting things on the horizon. When we do our referrals, we do not want to introduce administrative burden, right? We've had enough of that, okay? So we need platforms that's going to make it easy for us to go ahead, make that referral, but not add to our workload. Next slide. And here it is, the bidirectional feedback loop. What does that mean? That means if we refer the patient, We'd like to know what happened. We want the communication. And this is tied into the program. And so we make the referral, we give the basic information, and then the patient actually becomes a participant in the program and we get the feedback. So when the individual comes into the clinic, comes into our office, we can ask them, tell me what happened. What did you know? What difference did you make? We want to be able to enhance it. A lot of us have gone through motivational interviewing, and I know that we utilize those techniques just to get our patients involved in these strategies, but we want to carry it through that continuous loop. Next slide. So this is what we're doing in our office. Yes, we were definitely looking for a big response, and we're seeing it. So in our population health workflow, we utilize our EHR data to identify people at risk for diabetes mellitus. Now, I took a chance. I said, okay, I have this neat little quality button on my computer, on my EHR platform. And I want to plug in, remember, those three values, the yellow values. I plugged them in. And I've said, identify all patients greater than age 18 in our population, and let's see who we get. It literally took the computer less than 2 minutes to create a list of all the people who were in our practice that had the 3 yellow parameters. We were astounded. We were, oh my goodness. So we need to contact these individuals and communicate to them need for maybe additional testing, because some of them, the data was a little bit old and we could have filtered that too, but I really wanted to know what we had in the population. And so we communicated the need. We're concerned about you. Come on in, let's talk about this. And we review the results for intervention and prevention. And it's at that time that I can introduce the patient to a strategy that was going to make a difference. I have not had one patient says, hey, I'm not going to do it because I really don't care if I get diabetes. Nobody's going to say that. And so I wasn't running that risk. I have had patients say, I'm really overwhelmed right now. There's a lot going on in my life right now. And that's when we have that physician-patient relationship and build up that trust to say, I care about you. And I understand that you have a lot going on, but I don't want to have this on your plate as well. That's what makes a difference, is when we actually engage the patient in their own care and let them know what it is that's happening in the information that can make a difference in their life. And so we implement those lifestyle strategies. And then we also plan it out. Once you go through the program, whether it's 3 months, 6 months, let's go back and see what that A1C looks like. And let's make sure that you understand how to check your blood sugar at home if you have a need. We did individualized PDSA. Now I'm saying we. I know my colleagues who are also in primary care, you are doing the same thing. And I'm here to help you make your strategies just a little bit easier. I didn't have an additional FTE in the office doing this. We actually plugged this in to the current workflow that we have. And that's what I'm trying to share with you. Next slide. So what are our resources? Because clearly, not all of us have this wonderful myriad of resources in our own home, our own patient-centered medical home. So what else do we have? We could go to the next slide. Well, we do have our partnerships with the North Carolina Medical Society. I encourage you to please visit the website and then look at the pre-diabetes information that's available. There's information via the AMA. They too have partnered. And then we have our own North Carolina Department of Public Health. So we have 3 major partners who are helping us. But not only that, they too are reaching out to patients in other ways. And together we can really impact what's happening in our patients' lives. Next slide. This is a tool that I really wanted to get to. So many of us are part of accountable care organizations. I call them affordable care organizations because there's a whole lot of reasons on how we can participate and the difference that it makes for our patients. Well, in our ACOs, or even if we're not part of an ACO, we want to know what is the return on investment. We're going to put all of this energy, enthusiasm. We already spoke about the billions of dollars in terms of cost. We spoke about the burden of finances, and we also spoke about the burden of the disease on the individual. Now we have a way of actually calculating how much medical cost savings, what it can do for your patients with prediabetes. And this neat little calculator, I encourage each one of you to go online and pull this up, and you will be amazed in terms of the savings. Now, for this particular example, the savings was over $8,000 in medical expenditure per each participant, okay? Because they didn't progress to having type 2 diabetes. We intervened when they had pre-diabetes. Now multiply that out across your population, which the calculator does. I've plugged in all kinds of numbers. I've run all kinds of scenarios. I encourage each one of you to do that. Look at what you are losing if you don't participate, and yet you have all these resources available to you. We could go to the next slide. Wow, that is a lot. And this data, and we're looking at it over the 3-year ROI, what you're going to see. Now, I have to tell you, I gotta put my glasses on for this one. And Franklin, feel free to jump in. As a matter of fact, I'm gonna let you run this one through and then I'll come back in.
Well, as you said, Dr. Smith, this is a very powerful tool, and we put it out on our website for folks to use, and Dr. Smith mentioned that. But if you will go, and this can be used by healthcare organizations, this can be used by small business. We recommend it to a lot of Alliance members that they use this. This is a very powerful tool because it will tell you how much you're going to save, as Dr. Smith said, but you have to go in and put in your numbers and then push the buttons and download the results. And I would recommend to anybody who's on the phone with us today, anybody that downloads this information, to please use it in your organization. And then you will see why you should take the DPP plunge and make the commitment with your organization.
You know, I think, and being part of a Medicare shared savings program, which is part of the ACO, when we look in terms of the net savings over a 3-year time frame, this is amazing. If physicians truly feel like that our ACOs and our shared savings programs are going to have impact, this is just one disease that we're taking care of. One disease. But we're trying to prevent diabetes before we even get into the cost that's attributed to our population. And this was amazing when I saw this data come out. And I really encourage each one of you, plug in your own population, plug in your ACO population, your clinic population, get the numbers and plug it in. And you know, once you do that, and then go ahead and create that workflow that you can utilize in your own clinical setting in terms of how do you identify those patients and how do you go through that same process that we go through in our office. We've had opportunity of doing it right, and we've had opportunity of not doing it so right. And so that's what we call a plan, do, study, act. We can modify. The bottom line is, how can we get our patients engaged? And this is what you're going to see in terms of the cost savings. And if you can just put the project and try to use it. Next slide. So we're at the end of our discussion, and I recognize that I gave a lot of information, but hopefully more just tight bullets. The first is identifying those individuals who are at risk for prediabetes. We already spoke about the cost burden. And now we really want to figure out how can we get this implemented in our practice. I am not trying to create administrative burden, no way. But what I am trying to do is to make sure that every person in North Carolina has opportunity to good quality care, accessible through your practices, through the work that you're doing. And we really need to pay attention to efficiency and cost. And so that's what we know of as the quadruple aim. And this program definitely fits within that scope. I believe we may have one other slide. Oh, yes, my happy face slide. So Mary Alice, she completed the program and had additional lab testing, and her A1C was 6.0. She enrolled in the diabetes prevention program, and upon completion, she reduced her BMI to 27. Remember, I said 5% weight reduction. And her repeat A1C was now at 5.6. Mary Alice was taken out of that risk pool. And that's what we're trying to achieve. Now, yes, I did have a patient who was diagnosed with new onset diabetes on today, but I also had another patient who participated, and he said to me, I don't ever want to use medicine for diabetes or cholesterol for mixed hyperlipidemia. And we looked at his numbers today, and he kept saying, Doc, look at my BMI, look at my weight, look at my weight. I was like, wow, you brought your BMI from 31.7 and you're down at 29.6. That meant he went under the BMI 30 threshold. And we looked at his laboratory, and he did. He had brought his A1C down to 5.6, and he brought his LDL down to 70. And he was really tickled pink. Now, I was embarrassed because I didn't look at his body weight. He says, I've been doing all of this work and you didn't look at my body weight. I said, I was looking at your body. You look good. You know, it's like you make a difference. And so he really was a shining example of what can happen if we put forth a little bit of effort. Do we have another slide? Our commitment slide. North Carolina is taking a stand against diabetes, and we ask you to please join us in our efforts. We want to hear your stories, just as I've shared mine, and hear the good news. And what are your strategies, and what works and what doesn't work, and how can we actually do this together? We are excited about it. We know that we have partners who really have put forth some effort, and I don't want any of us to be without this resource. So let's get your name on the list, make the commitment, and help us to make diabetes-free North Carolina. Next slide. There's a survey that we're asking for each one of you to please go to, because again, we're trying our best to make sure that this rollout is something that's received by all areas, all physicians, all clinicians in our state. And your feedback helps us to, what can we do a little bit different? At this point, I can entertain any questions if we have them. And if Franklin would like to add any more comments, this is a perfect time to do so.
Thank you, Dr. Smith. I would just like to add an additional request of anybody. Like I said, would you go to the North Carolina Medical Society Foundation webpage in our Diabetes Free NC and add your name to the pledge? Please do that at your earliest convenience.
Wonderful. Thank you both so much. That was packing in quite a bit of information, but it was very helpful, very enlightening. At this time, we do not have any questions, so I will just say if there are questions that come up at a later point in time, or maybe when you're going back and rewatching this recording, if something pops up, please don't hesitate to reach out to us. You can reply to the invite email and we will make sure to get those addressed. So without further ado, I would just like to once again thank Dr. Karen Smith and Franklin Walker both for your time today and giving us this fantastic presentation. I know you're both very busy people and your time is very valuable, so we appreciate you taking the time out of your day to join us today and to share this information with our members. So once again, just as a reminder, today's session has been recorded. We will email out a link so that you can access that recording on our YouTube page in about a week. So please stay tuned to your emails for that information. And again, if any questions come up, please don't hesitate to reach out to us at the Medical Society. Thank you all again so much for your time. Dr. Karen Smith, Franklin Walker, thank you very much. I hope you have a wonderful day. Everyone take care, stay safe, and be well.